Oh, yes.
Hello, hello, everybody. It is Friday night, and we are here with the one and only Dr. Audrey Yoon.
Hey.
Thank you so much for being here tonight. I just want to go ahead and go live on Facebook for a second before we start. And if my kids let me, let's see. Hold on just a second. What I'm trying to do. I want everybody to turn their videos off so we can really see Dr. Yoon. Very good in our screen. There you go. Thank God it's Friday. Yes. Tell us in the chat box where you're from, where you are. Ange, did you share it on the professionals page?
Not yet. I'm working on it right now.
Okay, so let's do that really quickly because we have a very important announcement for everybody before we start. Let's see. Okay. Oh, there it goes. It's showing that we're live now. Let me turn myself down. I'm listening to myself. How's everybody doing? Tell us over here. Oh, Ohio. Where else are you guys from? All right, let's see. Go ahead, group. Okay. Oops, I posted in the wrong group. Sorry. I'm posting in the wrong groups. Renata. I just want to tag everybody from our group really quickly so they join because this is a very important announcement that we have, and I don't want anybody to miss it before we start our live. And then we're going to get off of Zoom, off Facebook, guys. So this is a special for our wonderful members. Okay, we're ready. There it goes. I got it, Ange.
Okay, thanks.
Awesome. All righty. So I am going to start by introducing our wonderful speaker. Let me open up what I need. Here we go. Ta-da! Dr. Yoon completed her orthodontic and pediatric dentistry residencies at the University of California, Los Angeles, UCLA, the nation's preeminent program of its type. She also earned her Doctor of Dental Surgery and Master of Science degree, completing extensive research in obstructive sleep apnea at UCLA. Upon completion of her dual specialty degrees, Dr. Yoon was invited to join UCLA's School of Dentistry as a clinical faculty. She is also an adjunct assistant professor of Stanford Sleep Medicine Center at Stanford University, an honorary assistant professor of orthodontics at the University of Hong Kong, an adjunct assistant professor in orthodontics at University of Pacific, and a clinical associate faculty at Tufts University School of Dental Medicine. She is also a co-director of Pediatric Dental Sleep Mini Residency Program at Tufts University. Using state-of-the-art technology, Dr. Yoon is committed to achieving clinical excellence and ideal case results. She is an Invisalign VIP Platinum provider, which is only, I do not know how to say that word. Thank you. To the top 1% of Invisalign doctors. Dr. Yoon's field of expertise includes the effective utilization of orthodontic temporary anchorage device, TAD, to minimize surgery and maximize aesthetic successful outcomes. Dr. Yoon is a collaborative team member at Stanford Medical Center in the sleep apnea research. She has developed a pioneering distraction osteogenesis maxillary expansion dome technique for the treatment of obstructive sleep apnea and has co-authored chapters in several leading ENT textbooks. She's one of the leading orthodontics to perform the surgery-first approach for orthodontic surgeries and has developed its application for maxillomandibular advancement, MMA surgery for OSA. She's also an expert in customized sleep oral appliances and early interceptive orthodontics in children for craniofacial growth modification. She's also a proud mother and a loving wife. Dr. Yoon, she's a firm believer in strong family core values. She carries this philosophy into her practice, giving her patients the care and attention they deserve, just like a part of her family. So I apologize to everybody that we had to cut her bio because she does everything. We love Dr. Yoon. We know how incredibly busy you are. Thank you so much for being here. So first, I know today's topic is expansion and growth modification protocol. But before we really start, we are here live on Facebook because I want to give her the opportunity. Kids, please. Sorry. So let's talk about, oh my gosh, Zoe, do not make him scream. Oh, you got it? Is this me that's sharing the screen?
I am actually
You
sure.
got it? Awesome. All right. So let's first talk about the World DentoFacial Sleep Society. What were we missing and how is this incredible society going to fill the gap?
So thank you for amazing, lovely introductions. As hopefully everybody knows me now, my name is Audrey. Let's talk about a little bit about dental sleep medicine. So, I mean, right now, the dental sleep medicine field, I mean, I've been in this field for like over 10 years, but like the past, I say 5 to 7 years, is growing exponentially. Now, like everybody talking about it, but there is no guideline, like still very like Wild West. If you're looking at the medical organization, there is a American Association of Sleep Medicine for US, and then internationally, there is a World Sleep Society. But for dental medicine, we have American Academy of Dental Sleep Medicine, like ASM, but it is only for US and mainly just focus on the oral appliance. And there are so many countries where there is no established educations, no guideline for the dental sleep medicine. And then a lot of countries just, they don't know where to start. And so the Global Society for Dental Sleep Medicine was very, very needed. So I'm excited to announce that we launched the Dental Sleep World DentoFacial Sleep Society. I wanted to emphasize that we are not just talking about the oral appliance, because we're gonna learn about gross modifications, craniofacial changes, surgical approach, functional approach, myofunctional therapies. So I named it not just World Dental Sleep Society, I named World DentoFacial Sleep Society. So our World DentoFacial Sleep Society, it will be nonprofit, a professional membership organization dedicated to advancing dental facial sleep medicine worldwide. So the purpose of World DentoFacial Sleep Society is to increase the dentist, surgeon, allied professions, myofunctional therapists, even the public's awareness of a sleep disorder worldwide. And eventually, one of our final mission is come up with a proper education and international sleep medicine guideline. So we are having a committee. Our committee will select, review, publishing guideline for preventions and treatment of sleep disorder. Currently, everybody love our society. Like 17 countries dental sleep society agreed to be affiliated with our society. So far, none of other dental sleep societies say no. And also our sister the society, the World Sleep Society, will be one of the major supporter. Also, our vision, World DentoFacial Sleep Society will manage a variety of programs that engage the global community of like dentists, surgeon, myofunctional therapists, researchers, and professions, any professional as well as the public. So we'll have our first official meeting in Rio, Brazil in October in 2023, which will be the joint meeting with the World Sleep Society. And we'll also have a virtual meeting annually, as well as online courses and monthly feature lecture series seminars. So if you go to the DentoFacialSleep.org, the website now is open. And we're gonna start doing our monthly feature lecture series probably starting next month.
Oh, so exciting. I think I just took my video off. I don't know what I'm doing. I've pushed too many buttons all at the same time. Clearly, I'm not good at this. Oh, that's great. This is so wonderful. I'm so excited. And I know Renata is super pumped about being in Brazil too.
Yes!
Although you're not saying you're going, but I'm going. I want to go.
Yes, I want to know who's going to be in Brazil here. You guys let us know in the comments. I'm definitely going.
So we're gonna have a joint party. So we're gonna have a first party, launching party on the beach house in Rio.
I remember Dr. Sally talking about that.
We just reserved the gated because it's also we want to be safe, so it's very like a safe gated big huge beach house. We already secured the venue, and yeah, we're gonna have a big party, luncheon party as well. But we also gonna have like amazing courses, all the global leader worldwide, and then also from all different specialty.
Oh my goodness, Marissa's saying, see you in Brazil. Yes.
Yes, and then we are talking, we are still speaking with the Brazil myofunctional, like a therapist group. So hopefully we're gonna have a huge luncheon party. So please come. Time to have a party. We know how to.
Definitely. How exciting. And we are so proud that you decided to launch this and let everybody know about what's going on first on Airway Circle. Thank you. Thank you so much. I really hope that everybody here listening, we have about 30 people on Facebook right now. I hope you guys join. I mean, this is so important. They're doing such a wonderful job that needs to be done. Wonderful work. So let's start with our webinar. Who is ready? Anybody on Facebook? If you guys are members, go into the member area and you can get the link to join. We are leaving Facebook right now. So thank you, everybody. Have a wonderful night. Let's stop the live stream. Ta-da. All right, let's start with our first question.
All right.
What is your growth modification protocol?
All right. So this is, let's see, I will share with another. Maybe I share with my presentation a little bit.
Okay. Awesome. Awesome. That is so exciting. I remember whenever I was at Stanford, you guys were talking about getting a house, and I'll be everybody's translator. I'll make sure everybody stays safe. I'll do before we go, I'll do a Brazil 101 safety protocol.
So let's talk about the orofacial growth modification. So when we talk about the growth modification, this is something that we need to think about, because the sleep disorder breathing has a large spectrum from mouth breathing, snoring, upper airway resistance syndrome, mild sleep apnea, moderate sleep apnea, and then the severe form of obstructive sleep apnea. And it is continuum and progressive spectrum. But however, currently in the US medical insurance cover any type of sleep apnea treatment only after diagnosing sleep apnea. And if our children are only spectrum, they are like snoring and mouth breathing. And we know also there is only a specific time window to develop the certain structures. You're gonna wait until it gets worse. And then sometimes it's too late. So when we talk about the orofacial growth modification, we need to have enough rationality. We have to really intervene or not, and then when to intervene and where to intervene and how to intervene. So the key to pediatric sleep disorder breathing is like, first, we need to recognize the risk factor early, and then we have to set up the treatment for long-term stability. And we have to think about ways like structures and then functions and how we work together. And we also see, I mean, everybody has their genetic, the potentials, and we want to maximize the growth potential. And while we are maximizing the growth potential, we want to make sure that improve the muscle tone and response. So we want to make sure that function is getting there, so that our goal is to promote the positive orofacial growth. And we want to grow our child, the airway and face, like a healthy and more positive. So when we talk about the growth modification, I have to mention my mentor, Dr. Christian Ginamino. Past years, his passion was look for preventive treatment for sleep apnea. That was his like the last 10 years of work that like Audrey, sleep medicine is a preventive medicine. And he has to pressure me that like, Audrey, you need to come up with a growth modification protocol for children. And like a lot of times, like we don't have enough evidence. I think nobody gonna read my article, nobody gonna listen to me, or I don't know it's gonna be published. And then they say you need to start with something, some guidance and some starting points so that we can proceed and build more evidence from there. And I thought that because there's still, see, like when we're talking about publications, if there is not enough evidence, if we're talking about the opinion piece, it's really, really hard to publish. But I just came up with a kind of rough the protocol where I divided to 5 different stages. So like a preschool, primary dentition age, and then early mixed dentition, late mixed dentitions, adolescent, post-adolescent stages. And then even though there is no direct evidence in orthodontic, like long time, we've been studying anatomy and craniofacial growth and development forever. I mean, we had a full curriculum for 4 years of our residency. Even though we don't use it, we learn a lot. So I came up with this pediatric growth modification protocol based on our literatures that how we can maximize our growth potential and how we can change the trajectory of the growth so that we can direct our growth more favorable, and which structures, when is the best time to approach. And if we miss the opportunity, what is the another alternative, and how we can work with the myofunctional therapists and surgeon together. So I kind of proposed this for a few times on the World Sleep Society. And I don't know, it's like Dr. David Gazal and then the Dr. Kushida at the Stanford, they think that, yeah, it's the time to publish the article. So actually they're like strong supporters and want to be a co-author to the protocol. So right now we are in the process of a publication to the journal Sleep. But getting a brief look at the guideline, I divide into 5 different developmental stages, like using chronological ages, dental stages, and cervical vertebra we call skeletal ages, and then point out the characteristic of skeletal growth of each facial complex that's relevant to airway growth. So we talk about cranial base, nasal-maxillary complex, mandible, lymphoid tissues, and the functional. And then I propose to the strategy for each structure growth at different stage to maximize the growth potential and then improve the trajectory of a growth pattern. So this is actually even kind of an update. So if you wanna see, myofunctional therapy, Alicia Paskey,
Yes.
she helped me for the functional part. So let me see. So if you're looking at
Wow,
help me for this little functional
this
part.
is amazing.
Yeah, so we're talking about the breathing, sucking, like swallowing coordination at which ages, and what is our goal and how we work together. So it's a kind of whole day if I talk about.
Yeah.
Yeah, we actually we learn a lot. That we kind of mini literature review, and then we see, like for example, maybe I will point out certain things, like if you're looking at the lymphoid tissue, like adenoid or tonsils, they also have their own growth curve. So if you're looking at the adenoid, their peak is age of 10 to 14, and then tonsil, the peak of 3 to 7 years old.
Wow.
And interestingly, the tonsils, the size is also, it goes the same of incident of pediatric sleep apnea incident. So it actually have the same graph. So when the tonsil kind of shrink, also we see the sleep apneas, the ages also reduce together.
Reduce. Well, that should tell you something right there, people.
And then, for the mandible, like for example, mandible growth is very tricky because a lot of orthodontists, like even during home my residency, we learned that if you want to grow the mandible, if you want to use a functional approach, you need to use for during growth spurt. So we thought that like class 2 corrector, we thought we need to use only like when they hit the growth spurt. So we wait like age of like per se 12 for the girl, like 11, 12, 10 to 12 for the girls, and then 12 to 14 for the boys. But because we look at the mandible growth spurt only after age of 7. Now I'm looking at their mandible. You know when the mandible grow the most?
No.
After birth, the first year. The first year after birth, mandible grows 17 millimeters. Average 17 millimeter first year. And even then, like a first 6 months. And then second year, mandible grow about like 9. And then third year, they grow 7. And then 5. And then after age of 7, mandible in average, I'm talking about average, 2 millimeter per year. They grow after 7. So they got plateau.
Wow.
They have what we call juvenile growth spurt, which is like about 10 to 12. It's like slight. And then when they go to growth spurt, 12 to 14, they get a little bit more. But we are talking about instead of 2 millimeter, they grow 3 millimeter or like 3.5 millimeter. And we are just focusing on like 1 more millimeter. But actually, if you're looking at the big pictures, there is so much you can do if you actually start early. So we are actually adding in our article, but currently, you know the pure Robin sequence, which is very, very small mandible. Currently in US, what they do is they call distractional stereogenesis, because those kids, when they are born, they cannot breathe. So when they are born, they just put them on ICU. And then like they just usually put the tongue out or bring the chin to like a literally holding, or they just put them in sedation until they get surgery because they cannot breathe themselves. And we call it mandibular distraction, where they cut the lower jaw and then they increase. But in Europe, in Germany, what they do, they're using the appliance. Looks like a obturator, for the cleft patients. Like they fill the palate, but then they're adding little more the plate behind, so that the plate kind of pushing the lower tongue and lower jaw forward. And actually the Stanford, now we are using that appliance. The whole US, the Stanford is only hospital. We are using those, we call AOP. And instead of the jaw surgery, if we just need to use those oral appliance only first 6 months after they are born, they don't need the jaw surgery, and they just catch the trajectory of a mandibular growth. It's amazing.
Wow.
And I think it is possible because that is the best time. And when they're born in their first 6 months, that is the best time that when you actually properly apply the proper appliance, you can actually do a lot of results. But we don't do that. That age for everybody, only for those like a severe syndrome. But they tell us a lot of things, that this is a huge area that we need so much potential. So in the futures, if we know that they have a sleep apnea gene and their small mandible, we know the whole family gonna have a sleep apnea. Maybe those patients, we actually act early for very young age to get the best result. But that is actually like
I have a question.
Yes.
What is going on in the first year? What are the things that are retracting this mandible the most, or slowing down the growth of the mandible the most during the first year?
So the first year, because the first year, what happened is that we need to have a teeth. So their mandible actually grow quickly to accommodate the teeth. And also, this is actually very interesting time. We really don't have many research, but when they are born, usually the mandible is super small, like all newborn baby looks like retrognatic, and then their tongue posture is very forward. So they're like their tongue is sticking out. But that's how actually the best position where they can still swallow. But when they are born, they can actually swallow, they can eat while breathing. Larynx didn't descend yet. But then once we start speaking, now the larynx going descend, and now the tongue also go backward. Tongue posture go backward. So the mandible has to really grow, otherwise everybody gets sleep apnea. So the mandible growing quickly and then tongue goes down. Let me see. And let me see. So this is the time where tongue displays toward the oral pharynx, and that actually affects the mandibular displace. And also the tongue itself, the strength is getting increased rapidly at this age. So like when they're born, if you're looking at the tongue strength, the rapid increase from the age of 3 to 6, and then after 6, tongue strength kind of still increase, but kind of slowly.
Okay.
Tongue strength is still developed until the age of 17, but the rapid strength they build up is the first age of 6. So this is like important for every aspect.
Wow.
And this is the time that speech develop. And this is the time that, breathing, suckling, swallowing, everything is kind of coordination get developed.
Is everybody else in awe? I know, everybody's speechless. This is wonderful. It's up to you if you want me to keep asking questions or if you want to just keep going.
Maybe let's talk about tongue size, because this is the myofunctional group. So maybe you are interested in the tongue a little bit.
Please.
My ortho group, we're talking about all these things. So like when they are born, their tongue is kind of forward positioned and they are kind of descending, but then also mandible kind of catching up. But then around this age, it's like 6 to 9. So like kind of not toddler, they're kind of the preschool ages. This is the time that tongue size kind of increase. And then I told you that the mandible growth is kind of plateau. So the mandible grows so much. And then when they're like 7 and 8, mandible doesn't grow as fast. Now tongue is growing fast. So this is the age where when you see it looks like a tongue is huge, like they're like compared to their mandible. And then this is also the time where the tongue looks like falling behind. So all these ages, like a lot of times when the kid has a sleep apnea, usually, they can be inside a nose issue, but a lot of time they're tongue falling. And tongue exercises and bring the tongue forward sometimes is the key for the sleep kids. And but then the mandible actually catching up. So I told you that little growth spurt, the juvenile growth spurt, and then they have a growth spurt. So and around this age, like about 10 to 11, now tongue size done, like tongue doesn't get any bigger. And then the mandible still growing. So around this time, it looks like tongue doesn't look that big compared to mandible size. So when you see the kids, you kind of get the idea that, for very young, like newborn kids, like tongue is forward, going back. And then now tongue is getting bigger, but the mandible doesn't catch. And then about 10, 11, mandible kind of grow. And then now they kind of stabilize. So I'm sure, I'm not the expert in the functional aspect, but I'm sure that is a lot to do with also functional development as well.
I have a question.
Yes.
I don't know if I can interrupt you. When somebody has a severe overbite, I've been having so many kids recently that just, you cannot even see the lower teeth at all because the maxillary teeth are covering completely. Does that trap the mandible? What should you do at that point? Do you wait? What is the best age? What do you do for a severe overbite?
I don't agree that every overbite need to correct it early.
Okay.
But however, so that is that is a discussion that when to start, and we don't want to over treat, and we don't want to fight with a crying keyboard. Like, I don't want to expand every 3 years old if it's not necessary. But also there is a lot of other functional aspect you need to really see. So I usually look at the family histories, like do they have any sleep apnea. Also, genetic is very, sometimes the genetic is very important. So I'm just looking at their mom's and father's face, and then we kind of expect how they're gonna grow as well. The overbite is tricky because a lot of orthodontists, actually there's one article in the orthodontic article we call bimaxillary expansion article by Stacy Coe, and then when we using the upper and lower expansion, we call bimaxillary expansion, the technique, a lot of orthodontists using that article and then criticize that you're going to make a sleep apnea worse if you do that. Because if you're looking at that paper, they have a mild sleep apnea and then severe sleep apnea. And then when they're using the bimaxillary expansion for the mild sleep apnea case, and if you're looking at sleep apnea, actually get worse. But then, because you're looking at only that data, but if you're looking at the whole pictures, if you really read the whole article, so they tried to find why they got worse. And then they found out that those cases we call brachyfacial, like a low angle cases, which is like a deep bite cases.
Yeah.
Those cases, if they just do bimaxillary expansions, doesn't really work that well. And then actually have a little bit dolichofacial, which is a high angle case, when they use expansion work. So those kind of very deep bite cases, we call class 2 division 2. A lot of time they're also class 2. So like a mandible actually feed it back. And then those cases, like the expansion doesn't work. I mean, basically that the paper was telling you, but think about it. When they have a deep bite, like now you learn, right? What happened? So tongue has no room to go, right? Tongue has no room to go. So they are falling back. But even though they are deep bite cases, even though they expand the upper, they are still deep, right? Mandibles cannot come forward because they have overbite. So even though they do expansions, mandible actually still back. And they imagine now you have a bimaxillary expansions. Also deep bite cases, also their vertical is very low. So there's no enough room for tongue. And the height, now you put 2 expander top and bottom, tongue has really no room to go and they are falling back. So for the deep bite cases, actually, I see a lot of time that they have a sleep apnea and then you are putting expander temporarily can get worse. So only way to get better is you need to, we call unlock the mandible. You need to bring the upper incisor out. And then now your mandible can come forward. Now you get better. I mean, that's so if expansion alone is not, so you cannot really blaming the expansion doesn't work. Actually, expansion is a part of procedure you need, but in order to get the success, you need to get expansion and then kick out the upper incisor out. Now you need to bring the mandible and now you get the obstruction site to resolve. So like if you're looking at, you see, am I sharing the?
Yeah.
Yeah, so when I put the mandible, I put this one basically everywhere here. That it's important that you don't need to really put the appliance, but at least you need to unlock the deep overbite so they allow the mandible grow. Otherwise, you are not done on the gross modifications. And that's why like they criticize, expansion doesn't work. because it's not just like you throw one appliance and it works for everybody. You have to see where is obstructions, and then in order to get obstruction, where you need to get there. So the deep bite case is very tricky, and sometimes there's the case that we don't get a lot of good outcome right away.
Mm-hmm.
But I mean, depending on the cases, doesn't mean like every bite case you need to treat. But if they have a sleep apnea in the deep bite cases, I recommend full treatment. So my phase one always include full. I don't just do the expansion. I do expansions and then either baby Invisalign or some braces to kick out the upper incisors and then bring the mandible forward to get the ideal jaw.
Depending if they are primary teeth on the upper anteriors or permanent teeth, do you choose between braces and Invisalign based on that?
I mean, that's a really personal choices.
Okay.
But now I use more Invisalign for the smaller kid. Is because especially the primary dentition, brace is tough for the primary dentition. Like, because when we do the primary dentition, it's not just straightening. We have to, we call primate spaces. We need to create a space between the baby teeth because their permanent teeth is going to be a lot bigger than the baby teeth. So I like to kind of develop the arch so that we have a space for all the permanent teeth to come out. So after expansion, I have to bring all teeth forward and develop the whole arches. And with the braces, it's easy to straightening, but making the spaces in between the teeth is tough. I mean, mechanically, I have to put some open core every single between the teeth. And then also baby teeth, they have more inorganic substance. The enamel itself of the baby teeth are different. So bracket always come up very easily. And sometimes the baby teeth, especially that have a sleep disorder breathing and they grind their teeth, like their teeth are very small, the same size as a bracket. Sometimes it's just mechanically tougher. And I thought that kids cannot wear Invisalign. Surprisingly, they do better than adults. You think the adult has some more excuses. They have to go potty and they have to go and drinking. But actually, kids, that once they become their routine, they have actually very routine. So once you become routine, actually, I get the better result. But I mean, everybody's different. It's very personal choices.
Amazing. We have a couple questions here. Chris is saying that she has a 12-year-old with an overbite, 90%, and the orthodontist said they want to wait for braces because of growth of mandible.
12 is I mean, even old school, 12 is the time to grow the mandible if you want to. That is the growth spurt. Yeah.
Right. You can keep going, or I have so many questions right now.
You want me to talk about more, or you have more questions that I can answer?
I have great questions, but I mean, I have some questions, but we are really enjoying this
enjoying this
chart. This chart's amazing.
What else? Also, this is a little bit, I'm not sure. So the Lisha helped me, but we're talking about the reverse swallowing pattern, like mature swallowing, we call tongue thrust habit, and those is also very controversial. So I mean, this is maybe is wrong. So please let me know, because we are still in the process of finalizing our publication, so we have still chance to change. But I think because I have to read the old article, that if you're using the pacifier, I mean, currently, we recommend to discontinue before age of 18 months. I don't know where the number coming from, but somehow if it's lesser than 18 months, their jaw development and then teeth development, they are very soft enough that some of them come back. But if but also depending on how severe they are using and how like strongly they suck. But so that is something that people ask all the time. Like my like parents always ask when to quit. Like give me the critical time, and I usually the 18 month is a magic number that you gotta stop before this age.
Awesome.
What else do you want? Maybe you are interesting about the myofunctional appliances for the tongue. That one, I mean, everybody's different. So it's very, very my personal preference that I like to use those the myofunctional appliance for any ages, but also very young age. So if I'm using those like a heavy class 2 correctors or functional appliance for to grow the mandible, as we learn, we want to use for, if we already past the age of 7, we want to aiming for the adolescent age, which is like 12 to 14, right? So if they're like 7 and 8, 9 years old, I mean, if they have a sleep apnea, I throw the class 2 corrector anytime. But if they're not really, they don't have really symptom, but they are small jaw, and then I usually use those myofunctional appliance, so that try to get the tongue habit and the proper function so that mandible can grow naturally. But in order to do that, again, you need to do expansion first. Okay, expansion, and then kick out upper incisors so the mandible has a room to come forward, and then we do proper functional appliance. So we use like, sometimes I use myo braces, healthy start. Those kind of help to guide the tongue where to go at nighttime. I know myofunctional therapist is wonderful, but while the child is sleeping, they cannot really control their tongue. So daytime, I recommend to do myofunctional therapy, but I also recommend to use those the functional appliance at nighttime so that the mandible can grow. And I have a lot of surprising success story, but I know some doctors that advertising that is the only thing you need. You never need a braces, but I never had really good cases that if I'm using only those myo braces or healthy start only to correct everything, it's really hard to do. It's you ask a lot for the kids. So I'm just using it more kind of functional restoration at nighttime while they're but I'm not expecting like whole dental changes with appliance.
What is the oldest age that you would choose one of these functional appliances versus going into expansion?
So to me, functional appliances, additional appliances. So I'm not using, so all my patients need the regular expanders and all other treatment, and then functional appliances is kind of my functional control tool. So it's in addition, unless the kids are like really small, they are like 3 years old, 2 years old, and they cannot even they don't look at my eyes, and or the parents not ready financially or emotionally. But then you see they need help, then those cases I actually give for those myofunctional appliances. But and then also I use for even adult, for the tongue thrust, those the tongue habit patient for adult, I do Invisalign to control the vertical, and then I throw them wear it nighttime so that they can do. And they also, I recommend to do myofunctional therapy in daytime, but also I ask them to wear nighttime. So like I use all ages pretty much.
Wow, that's amazing. I just know that there's sometimes whenever we refer patients, I've had 6 or 8 year olds or 9 year olds that were recommended the functional appliance only, and some of them were so transverse deficient, and I'm like, oh my gosh, at that age I just want you to just go ahead and get something else in there to push this growth a little bit faster. But who am I? I'm not an orthodontist. So this is good to know they use both.
I use also Invisalign for a very young kid. I think also one of the common question that Invisalign really gets skeletal expansions.
Yeah.
I think it does for very, very young kids. Because a very young kid, like we're talking about 3 years old, 4 years old,
Mhm.
I don't use a rapid expander anyway. So even though I use a rapid palatal expander, my expansion protocol is very slow because that age, their suture is so malleable. It's so
Mhm.
I do slowly, and even we do slow expansion, like all suture respond. So if for the kids is that young, I think Invisalign will still work. But even the age of the patient already hit the age of 8 and 9, we don't get that much scalar expansion. So I'm a professor at the University of Pacific, and UOP is one of the school where the Invisalign developed. So we do a lot of intensive Invisalign treatment at the UOP, and we teach and we do study. So we actually look at the Invisalign versus rapid palatal expander for the phase 1. And then we see how much skeletal expansion. And because sometimes if you're just looking at the teeth, looks like we get beautiful skeletal expansions Invisalign only. So we actually look at our data, and then we found out that Invisalign alone doesn't get enough skeletal expansion compared to rapid palatal expansion. But our age was, even the phase 1, our age was like 10 years old. But clinically, when I'm looking at 3, 4, 5 years old, I think we get some expansion. But the other phase 1, like if the patient is already like 8, 9, 10 years old, the Invisalign still get a lot of expansion, but not as much as the scalar expansions. So the Invisalign came up with a new expanders. Now they had a first the first study in Canada, and they're gonna do another round of a study. So what they made was a direct printing expander. It's like an Invisalign, but it covered the palate, and then it covered the teeth and it covered the palate, and it's a direct printing. So like Invisalign, but it cover, and then you change every day.
Oh.
So it's a lot stiffer. So like every day you change, and then you get more.
So you get expansion.
Yeah. So they are doing expansion for direct printing stiffer material. And they did the first round of study already, and they look at the data. They still see about 6-degree tipping of the first molar, but they got some scalar. So now they're adding more torque and tip so that the teeth doesn't get tipped. So now they are launching the second editions. Right now it's only for few provider to get the study, but
are you doing it?
Stay tuned. So I will participate in the second round when they come up with so they enhance, and then second round I think they're gonna get some US doctor, because US is hard to do any study.
Yeah.
First.
How exciting.
I
mean,
right?
That works. It will be so much easier. We don't have to fit the band and like,
I don't want to do it.
So,
Wow.
yeah,
Oh my goodness.
so they actually make it stiffer, and if that works, we can do like so much easier for any ages, and then we get more scalar expansions and no more impressions, no more feeding band, no more turning.
Wow. I mean, that key, my child almost swallowed that key twice already.
That's one thing. And then this is not Invisalign, but there is some other research out there. Also, there was a class 2, we call it like a twin block. That is what they're using. But the twin block or bio block, they're like bulky and so painful. And then has to be very bulky because have to have a good retention, has to be not breakable. But now, because we're all using now 3D scanning and 3D printing, so we are actually also kind of doing some study at the UP, that the direct printing of the BioBlock, but it's small. Okay, now we are using the nylon, not the acrylic. So it's a thin but very stiff. So we are also studying. So maybe those mandible advancements, so those like appliance can be very small and easy to use.
Wow.
And no more bending, no more, painful. I mean,
That
it's
is the future.
it's a coming.
So exciting to hear that. I know that we have a question in the chat that Angela is going to ask, but I had a quick question about increasing the vertical. I have seen some orthodontists put this material on the occlusals of the teeth. Is that what they're doing?
Increase vertical for?
Whenever they put like this composite material or something on the occlusal surfaces of the teeth, is that to increase the vertical? Is that also to untrap the mandible?
Oh,
Or
no,
no?
those usually when they have a deep bite and then upper teeth hitting the lower bracket braces. So they keep breaking the bracket.
Is that why?
Yeah, usually they add the little occlusal bump so that upper teeth cannot break the lower bracket, and then while the teeth are aligned, then because usually when they have a deep bite, the lower teeth are kind of extruded, so we need to kind of bring it down. But while we are bringing it down, you need to have a occlusal, or they have a cross bite. Like you have an underbite. I have an underbite and I need to jump the bite. Your upper teeth gonna be hit. It's not gonna jump. So then we add the vertical so they can jump, and then they bring it down.
Awesome. I was wondering that. Thank you. Angela.
Yeah. Oh, that's great. I wanted to ask this next question because I fit into that category. I'm getting my buttons put on for Invisalign for round 2 because I still want some more movement. And, when you know, so you ask for more torture. But what ages are appropriate for the new Invisalign expander? And are they for adults also?
Oh no, that is for kids. So we
want kids only.
So yeah, instead of expander. So initially their thought process was like Invisalign was good enough. You don't need expander because with the Invisalign we can expand quite a lot. But then now they are questioning the Invisalign expansion is really skeletal versus non-skeletal. So we did a study and then we found out not that skeletal, but also that a little bit older age group. So now they want to have more skeletal expansions. So they're gonna use those direct printing heavy duty expander. You change every day for like 1 month or 2 months. So that once you get the expansion, then and the rest of the teeth will be still Invisalign. But just instead of expander. So I think the timing will be same as the regular expander age. So probably up to age of 11 or 12, 13, maybe.
It's so exciting.
Wow. I have 2 more questions and then we're done. Is that good? How do you decide if a child needs expansion first versus a referral to an ENT to address enlarged tonsils and adenoids?
Yeah, because I recently published the article where after expansion the adenoid and tonsil shrunk, and actually the data, I didn't really expect that much the shrinkage, to be honest, because in my practice, maybe I say 5% of my patient end up canceling their adenotonsillectomy, and then maybe I say 15% I see like visually smaller. So that was kind of my estimated number when I did a study, and then like, oh my goodness, like we shrink a lot more than we thought. But then at the same time, I don't want other people misuse my paper that tonsillectomy is not necessary. Actually, that's absolutely necessary. Even though our data show amazing result, adenoid shrink only like 17%. and then tonsil shrink about the 30%, and still sometimes it's not enough. So I think it's have to go by case and then see the severity of the cases. If I see 3 years old, 4 years old baby who come to me that like severe sleep apnea or very symptomatic, like, and you see it affecting their cognitive behaviors, and they are like wetting the bed and they have so much behavior issue, you just go to get the adenoid tonsil removed, and then you get the instant result. Because also the neural development is the first age of, 0 to 6. Like most of your brain development is done when you're 6 and 7 years old. So you don't want to wait until age of like 8 and 9. Also tonsillectomy success rate go dramatically down after age of 8. So tonsillectomy success and the effect is ideal before the age of 8. So if your patient you're 10 years old, there's no symptom or very little symptom, and the huge tonsil, I would just expand first. Because that age, like the tonsillectomy is not going to make huge difference. There is really no ideal, no really functional issues, just a huge tonsil. And then small jaw, there's no other issues. I will do expansion first and then see we can shrink the tonsil. Maybe they have a little bit of the airway issue, but those cases I will do expand more. But for younger kids, there is a cognitive the impairment. I will just go to expansion. I go for the adenotonsillectomy first. Because the expansion also showed the result, at least like our data, at least like 12 to 13 months. So you want to wait for, not same thing, you want to wait for 1 year, 2 years to shrink. And then if not, and then the tonsillectomy, you already missed the time to brain development. And so I think go by case.
Amazing. Any new research you're working on?
Some
besides what you just talked about, the Invisalign one.
I do some oral appliance expanders. Something that you guys are gonna be interested in. So me and Sorosh and Tracy Trent, some amazing pediatric dentists. We are doing some the labial frenulum, the grading system for all different ages.
Oh my gosh.
So I know, so we came up with a tongue grading tool, the grading. When we're looking at the labial frenulum, what I see is different ages. We need to have a different grading system, because when they are newborn, like it looks like everybody has a tie. And then when they have a primary dentition comes, and then they have a permanent incisors comes, you see the labial frenulum actually go up. So we divide it to primary dentition, mixed dentitions, and then like a permanent dentitions. And then we actually measure the labial frenulum, and we're gonna have our own bell curve. So and then so at that way you see like, oh, you are age of 3, and now you're like a little bit low, but you have a 30% chance that goes to grade 2 when you reach to age of 10, or you have like 90% of chance that it become normalized or something, So we are right now, we already have a data we are analyzing, and anybody volunteer to collect. We already have a data, but we'll come up very soon. We already have data. We just need to put it together and then come up with the labial frenulum.
Wow, how exciting! Well, how do you even have time for you? I know that was the last question that Angela had. What do you do to relax?
Do you? Is that even in your vocabulary?
I know. That's always a problem. When I go to the lectures, like you need to have 7 hours sleep. And then they asked me, so how many hours sleep last night you like, always so sleep deprived, but
I think all of us, I know all of us, we talk about it. It's like, do as I say, not as I do in this
So
field.
true.
But anyways, guys, this has been such a wonderful hour. Dr. Yoon, you're always welcome on Airway Circle. Anything that you need, please, you can always count on us. And thank you for spending this wonderful hour with us. We know how busy you are, so we're very appreciative of your time and your knowledge and you teaching us. This is wonderful.
Thank you. Thank you for having me.
Everybody have a wonderful night. I'm going to make a little post about tonight. I want everybody that's here tonight to go there and comment. So everybody that did not participate can be jealous.
That's right.
All right, guys. Thank you so much. Have a wonderful night.
Good night, Dr. Yoon. Thanks for
Dr.
being
Yoon.
here.
Bye-bye.